So, in addition to that, I give special appreciation to the rhyming yet very relevant title suggested by the organizing committee for my talk, From Callus to Crisis. Why minor amputations, minor foot amputations without major amputation? I bring greetings to from Government Medical College Trivandrum, my alma mater, and Saraswati Hospital, Palasala, a multi-specialty hospital with focus on diabetic foot, metabolic surgery, and laparoscopic surgery. Dear friends, I want you to see this video. So these are the unfortunate people we come across in our daily practice. This poor man is finding it difficult to put his slippers because of the severe neuropathy. And this is the crisis they finally reach, right? And my talk will be more on an atlas type of talk, not a hyphen theory, because it's a very important aspect in preventive podiatry. As you all know, the amputations, more than 80% of non-traumatic amputations are diabetes, and it's characterized by sensory, motor, autonomic neuropathy, and macrovascular disease. And this leads to ulceration, infection, gangrene, and amputation. And you have two types depending on the predominance of the pathology: neuropathic foot, where the neuropathy is predominant, and neuroischemic foot, where there is neuropathy but vascular disease is predominant. And as Dr. Ajaiyakumar said, you have multidisciplinary approach needed since it is a multi-system disorder. It's an end research. Actually, diabetic foot is a syndrome where all these work together and make the patient's foot dilapidated. And what happens in sensory neuropathy, you know, there is unnoticed or unperceived trauma. The lesion goes unchecked. The patient is not aware that he has developed an ulcer, and the pressure is there because there is no offloading, infection, repeated pressure, ulcer formation, and motor neuropathy adds to this condition because it has got weakness of intrinsic muscles. All the intrinsic muscles start from foot, ends in the foot, are affected first. A lot of deformities result, and you have deformities leads to pressure points leads to ulceration, as you can see in the diagram. And dear friends, the callus is the one which is the forerunner always. But unfortunately, most of the patients neglect the callus because there is no pain. And patient walks on the callus. What will happen? It is just like putting a pebble inside your shoes and walk. So there is pressure in the underlying soft tissue, and there is subcallosal hemorrhage. The hemorrhage occurs under the callus, and finally an ulcer forms. This is the basic simple mechanism of neuropathic plantar ulcer. Pressure point, callus, repeated pressure on the callus leading to subcallosal destruction of the soft tissue, bleeding, infection, breaking down of the callus, and ulcer, walking on the ulcer leading to a trophic ulcer. And what does autonomic neuropathy do? There is no sweating, no sebaceous glands working because the subdermal plexus is gone, there is sympathetic overactivity, and there is no moisture or oil in the skin. Fissure skin, dry skin, itching, and the risk of infection, and leading to ulcers and infections. And polyneuropathy, callus, abscess, and a trophic ulcer, repetitive mechanical overload, which is totally unperceived. And these are the factors which contribute to foot ulceration. The body prominences occurring as a result of motor neuropathy, the limited joint mobility, deformities, callus formation, previous foot ulcer, new charcoals are property. The extrinsic factors you all know, patient will have no idea where he stand, where does he walk, isn't it? He walk without any footwear, inappropriate footwear is not recognized by the patient because there is no pain, and he is more prone to falls and accidents. You may have objects inside the shoe which is totally unperceived and patient walks with that sharp instrument in the shoe. Their activity level is not at all controlled because he has no pain. And you should know this concept because it's a preventive podiatry oriented lecture for non-surgeons or physicians and family practitioners. If high-risk foot is a foot which has any one of the following: neuropathy, ischemia, deformity, history of previous ulceration or amputation. Dear friends, you are all very busy practitioners and you don't have the time to spend with each foot, so I recommend you to spend at least 2 minutes to both feet, isn't it? That is 1 minute for one foot, right? Examine the foot for ulcer, calluses, blisters, macerations, skin breaks, infection. Examine the toe nails. Identify any nature of foot deformity, any foot deformity. Examine the shoes. Observe patient's ability to perform foot care. Examine by observing them how they replace socks and shoes, how they wear their sandals. So in the examination, you have to see the nails, skin conditions, foot deformity, and you have to assess the vessels, and you have to assess the nerves, and if there is an ulcer, please assess the ulcer. So you can have a lot of nail problems like this. Nail can be thick, too long, ingrowing toenail, fungal infection, wrongly cut nails. You can see the first picture. It looks very clean. Correct. When you look carefully, it is a time bomb. Why? There are velocities in all body provinces. First metatarsal head, fifth metatarsal head, heel. The soft tissue pad is almost disappeared. Only skin and the bone, isn't it? Very, very likely to ulcerate. Then you have fungal infections, you have skin changes, and a very simple test. You find an ulcer, just prop the ulcer with a mosquito forceps or an artery forceps. If you touch the bone, there is osteomyelitis unless proved otherwise. Dear friends, this was a callosity, a callus. And how devastating it is, I'll show you the video. This patient had callosity. Patient did not know about it. He was walking on the callosity and the whole foot has got infected, and this is harvesting a deep plantar abscess which has spread to the legs and pedals. So this crisis occurred because of the ignorance or unperceived trauma. Patient did not know anything while he walked with the callus. See how severe the underlying condition, you know. Finally, we had to sacrifice a lot of soft tissue. It has already gone to the leg segment through the posterior tibial artery area, and you can see the tendon. So actually, this could have been prevented completely by giving proper preventive podiatric care. Even if you save this foot, it will be totally biomechanically unviable foot. Dear friends, you can see two ulcers. The one was properly treated by a podiatrist. You can see well offloaded, and you have the sloping edges, and the ulcer has started healing. See the other one? Nobody cared, and it has spread to the flexor hallucis longus tendon, and then it has crossed the forefoot, and soon it is going to develop a deep plantar abscess. Fungal infections, you can see a simple fungal infection going into an infiltrating bacterial infection, and finally losing a lot of soft tissue. A small ulcer leading to catastrophes. And the second picture, you can see the callus was turning into an ulcer. The patient was walking on the callus, and the callus is breaking down now. Soon it becomes an ulcer. You can see the subcallosal hemorrhage on the big toe if you look carefully in that same picture. And this is a rocker bottom deformity with ulcer on the center. See, a small ulcer, but it looks whitish in color. What do you see is the tendon, flexor tendon. And this is the end result. It has got spread along the flexor tendon and reached the midfoot. And these type of catastrophes needing long treatment, costly treatment, long hospital stay, at the end of the day you get a very, very bad shaped foot which needs a lot of care in the future with accommodating foot care, plastic surgeries, isn't it? So tendons are real problems in plantar side in diabetic foot management. This is the route through which the infection spread to the deep plantar area. And the extensor tendons are also not spared. You can see that nail infection spread through the extensor hallucis longus. So this is otherwise called iceberg effect. What you see is a toe, and what harbored was a big central deep plantar abscess. So this is the famous statement among podiatric surgeons: a diabetic foot will never ulcerate spontaneously. He says the unperceived trauma, isn't it? So when you give a very good preventive podiatric care, you can prevent 90% of ulcerations. And this is very important as far as a general practitioner or a diabetic practitioner is concerned. You have to inspect the footwear of the patient. It may not be always like this. You can see the next film. The poor man had an injury by nail through the worn out chappal. You can see that the sole was gone already, and he developed a prick injury in the first metatarsal head, and finally ended in an amputation. So offloading is a very important thing. Whenever there is an ulcer, you have to avoid pressure there. A lot of offloading methods are available, total contact cost is the gold standard, and we have some contributions there. This is a very convenient one called Mandakini offloading device. It's an air cushion offloading device made by a pair of surgical gloves and an elastoplast bandage. And if the patient is too poor to buy a footwear and all, you can use this type of offloading in his footwear, a temporary offloading method. And if vented form is costly, in that place you can use ordinary sponge made by used by the upholstery people. And footwears are very important in offloading. And pedicure, a very important part which should be made as part and parcel of foot care for any diabetic patient with chronicity. That you have to ensure patient gets an opportunity to see the foot every day, at least once in a week. So you have to implement pedicure, self-pedicure by the patient can do it, or by the close relative. So a lot of small preventive podiatric measures are there. This is a simple callus cutting. Just remove the callus using a 21 blade or a 15 blade, depending on the thickness of the callus. Regular callus cutting prevents ulceration because the pressure on that callus is gone when the thick callus is removed. And a lot of small procedures which we can do. This is needle genotomy, where you use an 18 gauge needle to sever the flexor tendon and straighten the toe so that the ulcer in the pulp or tip is taken care of. And my dear friends, a lot of preventive podiatric surgeries are there, like tendoachilles lengthening, gastrosoleus recession, Callus arthroplasty, and you can do preventive surgical offloading to prevent ulceration. And take home message, a callus is not just a skin deep one, it's a marker of underlying pressure, deformity and neuropathy. Therefore, minor complications can lead to major complications. Never ignore foot complaints, no matter how minor they seem. Every missed callus becomes a crisis. If offloading is not done, the patient walks to death. Please keep this sentence in mind because it's a very silent process going on. One by one, patient develops complications and finally it ends in mortality. Foot care is not cosmetic, it is life-saving. Act early, act fast. Save the foot before it's too late. My dear friends, thank you for the wonderful opportunity. You can save a lot of life. Save limbs and save life is our slogan and be part of our mission. Thank you very much. Any question, I'll be happy to answer.
Anybody has any questions? One more presentation, sir. Really nice. Callus is a very underlooked because a lot of patients have it and patients think it's fine, nothing's wrong with my foot. But then it's a taking time bomb, like you said. One day it's going to break and then it's going to cause frustration. I've seen a lot of patients like that. So thank you. That was a very important topic and the presentation is a lot of pictures was very explanatory.
Thank you, sir. One question. What is the role of intravenous antibiotics in the diabetic foot ulcer?
So, a role of antibiotics in diabetic foot ulcer is if the wound is infected as part of, as Dr. Srikumar was describing, the antibiotic has got a role if there is proven infection, and infection in diabetic foot will depend on the severity of diabetic foot. For example, it can have, if you have a deep plantar abscess, but how many antibiotics, how much antibiotic you give, there is no effect unless you have surgical drainage. Antibiotic has a role provided it is combined with proper surgical drainage. And there is strict guidelines in antibiotic usage in diabetic foot, and you have international working group for diabetic foot, and the IV antibiotics, oral antibiotics, all depend on the severity of the condition and the culture result.
One more question. What is your experience and comment on antibiotics beads? Bead.
Yes, that's a good question, and it is widely used in podiatric surgery, in osteomyelitis, deep-seated infections, and patient has got multiple comorbidities. Your local antibiotic delivery system seems to be very effective, and antibiotic beads is one among them. And depending on the cultural sensitivity, you can make antibiotic beads, or you can make antibiotic beads with very wide spectrum antibiotics without even getting a culture report if the condition is emergent. This is widely used in our specialty.
Good question, Dr. Again. One question is, what percent of patients will comply with this preventive podiatric care? How they come for preventive?
That's a very important question. I believe he has purposefully asked that question because it is very difficult to convince a neuropathic patient to even wear the footwear regularly. I have conducted a study of the usage of custom-made footwear. Once we prescribe, they make with 9,000 rupees, 10,000 rupees maybe, but the usage is very, very poor. So their compliance is very poor. For that, you need a dedicated foot care team. You have to hammer them just like nursery school children. So it's a very important question. Patient has got no complaint, and surgeon's problem is, or the physician problem is, no complaints, no examination. So altogether, the end result is very bad. So compliance is the most important thing we need for successful outcome.